Good evening to all my colleagues in India and around the world. Um, and I'd like to begin my presentation by thanking the organizing committee and specifically singling out Dr. Bharath for his kind invitation for me to present on this very interesting and important topic. By the time you view this recording, it'll be Sunday morning in Canada, and there's at least a couple of inches of snow on the ground, so it's very lovely and picturesque. So, without further ado, I'll get into my presentation. I've taken the liberty of changing a little bit the title. We're talking about separation surgery and day surgery unit, not daycare unit, in metastatic spine disease. My disclosures are fairly straightforward, nothing to sort of conflict with what I'm going to be presenting on today. The objective is really to introduce the concept of minimal access spine surgery, or MIS, in metastatic spine disease for separation surgery, and to provide some illustrative examples. The outline will be a case illustration, talk about definition, get some rationale behind the use of MIS, and some of my lessons learned over the years. So let's begin with a case presentation. This is a history of a 71-year-old man, initially diagnosed with metastatic pleural mesothelioma. He undergoes chemotherapy. He undergoes radiation therapy for a lesion now that's been identified at T4, and now presents to you a few years after his diagnosis with the following images. And the question is, what do we do with this individual? What's our next step? So here's some examples of CT scan. Suffice it to say that over the course of a few months, there's been progression. And this progression is quite significant because when we look at the MRI scan, you can see that there's epidural disease and deformation of the cord. So he qualifies as what we would consider a Bilski grade 2 or even 3. So in summary, we've got a 71-year-old man, very high functioning with an ECOG 1, normal neurological exam, but some very worrisome images. Now, in order for us to navigate and understand what can we do for this individual, or what should be done for this individual, there's several different characteristics that we pay attention to, obviously. Neurological status, oncological sort of status, mechanical issues, and systemic issues. And with all of these, we try to identify what is the best course of action, whether we need stabilization, whether we need to do just resection of tumor, whether we just need to do radiation, etc. So before we try to answer this question, let's take and look at minimally invasive surgery, MIS or MASS. And this is a nice sort of graphic representation of how far back this entity goes, and it's at least a good two decades now, and you can see the number of publications has been rising gradually over the decades. The concept, though, of minimally invasive surgery is not just making a small incision. It's really thinking about and incorporating concepts of invasiveness. And in the invasiveness, we think of a continuum from the least invasive, such as radiation treatment, to the most invasive thing we can do is formal open surgical procedure. And with these, there's even differences in technique. But if you think about an en bloc resection, that's probably the most invasive thing that we can do. And you have to think of the goals behind all of this, but you have to think of the impact on other treatments for cancer treatment. So the overall impact on management and adjuvant therapies needs to be kept in mind at all times. The rationale behind minimally invasive surgery, or MASS, is really to minimize the amount of muscle trauma and denervation and ischemia that occurs. And this illustration here with an axial cut in the lumbar spine illustrates quite nicely the amount of stripping of muscles and disruption of muscles that we have to do in ordinary open surgery. And that's represented on the blue side versus the green side, where there's splitting of the muscle and making our way through the fibers and disrupting the muscles as little as possible. Now, when we were looking to do this minimally invasive surgery or MASS, we need to sort of incorporate that in the overall flow of the patient. So this is where the concept of day surgery has really been fostered in our institution and has been something that's been very important. But in order to be successful at day surgery, you have to think of it as not just what you do in the OR, but you have to think about the entirety of the flow or the pathway of the patient in their overall management. And this begins at before the surgery in the ambulatory setting or the pre-admission setting, where there's some education that's provided, there's reassurance, there's managing of expectations, there's things that happen during the surgery itself, and then immediately after in the recovery room, in the day surgery unit, and then later on post-operatively in the clinic, etc. This is a topic that's been studied quite extensively in my institution, and these are just a couple of examples, but we've really looked at this from a qualitative and quantitative aspect, looking at both from the patient's perspective in terms of the positive experience and the focus on, a sincere desire to be home and to be kind of carry on with their overall quality of life. And also to look at, from a quantitative point of view, how safe and efficient this really is. And all of this experience has culminated in our ability to sort of extend this to areas such as metastatic spine disease. So, thinking about our classic surgical objectives, well, when we're talking about metastatic spine cancer, really there's three classical objectives that I would refer to. One of them is getting tissue for diagnosis. The second is getting neural element decompression, and finally, spinal bony stabilization. However, in this day and age, we now have the ability to think of a modern surgical objective, and that includes all three of those objectives, but also to incorporate the considering surgery as an adjunct to radiation, making radiation therapy safer. Let's come back to our case in point. This is the gentleman that presents with a high level of functioning and this epidural disease. What are we going to do with him? If I take him and do a big operation and I do, 2-3 levels above of instrumented fusion and 2-3 levels below and decompress him, etc., I will accomplish my objectives. However, this will disrupt his overall flow of management for his cancer care. He'll need at least 2-3 weeks of vacation, possibly even 4 weeks of vacation without any adjuvant therapy, because I want his wound to heal and not to get issues with infection, etc. And so this disruption can actually lead to quite a bit of spread systemically of his disease and get him into quite a bit of trouble. What was chosen was a minimally invasive technique, and here's some pictures of what it looks like looking through the tube, using the microscope, and looking through the tube at the lamin at the very top. Once the lamin is open and looking at the epidural space with the epidural decompression. And then the last panel in the middle is really looking through that area and into the vertebral body where I've put some cement to provide some stability. And the idea here is to provide, and this is an important concept because radiation has evolved over the years, and what we're looking at here is a delivery of radiation in a very focused fashion that allows to minimize the dose that the spinal cord gets and therefore minimize the chance of complications from it. But I would draw your attention to the lines of demarcation of where the doses are being carried, and you notice that in the epidural space you have to drop off the dose very, very quickly. And so if you don't have that little bit of buffer, that 5 to 10 millimeters of space, what will happen is you'll under radiate that area, and this will cause for local recurrence to happen exactly at that area. We use Bilski grading system to quantify how much epidural disease we have, and in this slide, which is quite busy because we've got the Bilski grading system, but I'm also referencing one of our initial publication that looked at when we took patients with Bilski grades 3s and 2s and brought them down to 0s and 1As and did SBRT, we're able to demonstrate that local control for that area could be brought up to 84%. So for this individual, this was chosen as the most sort of optimal course of action in order to get local control and not disrupt his overall flow management. So, what are the take home messages? Well, I think the important points here are really to focus on quality of life, look at each individual very specifically. Surgery is part of a multimodality therapy, not just in and of itself, and that you have to consider that the overall disruption to the systemic care plan. And so you have to think of how your surgery fits in with everything else. Thank you very much for your attention. Happy to take any questions if you have any.